So continuing this particular theme, we would like to first ask Kris, who is managing long QT syndrome registry, to say a few words about the registry and how it works. And after that, I will continue with a couple of further important topics related to registry. So Kris, if you could comment a little bit.
Sure. Can you hear me?
Yes.
Okay. So the goal of the registry when it was started was to gain insight into the natural history and clinical course of long QT as a hereditary disorder, so that more effective therapies could be found to prevent the syncope and sudden death events that often occur and accompany long QT. In treatment and outcomes, and to examine factors that influence the prognosis and quality of life. We enroll study subjects from physicians directly at times, but more often individuals call us themselves, having heard of us either from their doctor or online. We collect ECG and clinical information for the individual who reaches out to us. From that point, we begin to gather information and construct a family tree, which is very important to our study. We build a tree around the proband, who is the first person identified as having long QT in the family. That may be the person who reached out to us, or it may not be. Next, we enroll all first and second degree relative family members of this proband. Being a genetic disorder, gathering family history is an important step in determining which side of the family the mutation originates and who else may be at risk. Once we have enrolled and consented a subject, we ask for a copy of an ECG. ECGs are very important to our study, providing phenotypic characteristics of the disease. We are very interested in cardiac events in our patients: syncope, aborted cardiac arrest, death, and ICD therapy. Our goal is to increase the data on LQTS subjects with ICDs right now. While at the same time, we are trying to make it easier for our participants, we are sending out our annual follow-up in the ICD questionnaires at the same time, as some of you may have noticed, for those of you who do have an ICD. If you have had genetic testing, we request a copy of your genetic report. We cannot code a person as genetically positive in our database unless we are in possession of the actual report. Having an ECG and an accompanying genetic report allows our doctors and statisticians to explore the genotype-phenotype relationships of this unique disorder. All information you choose to share with us is kept confidential. Once the enrollment is complete, your family is assigned a follow-up month, as most of you know. Once a year, at the beginning of your assigned follow-up month, we send you the follow-up questionnaire. When you fill these out and return them, we take your information and enter it in the database. The information is then available to the programmers and statisticians for data analysis. Beginning in June of 2018, we have been able to offer our subjects the option of completing their follow-ups online. This option has many benefits, both to you and to us. We are still happy to do follow-up by mail or phone. If you do not currently fill out your follow-up online, but you would like to, please contact one of us, because we'd be happy to help set that up for you. The challenges sometimes for us with either mail or email follow-up are when we receive incomplete responses. That forces us to make guesses, which can be largely inaccurate. We realize that many people cannot remember exact dates of when events or medication changes occurred. That's true for most of us and it's very natural. But try to remember that your best guess is likely to be better than our best guess. If you fill out follow-up every year, we appreciate that very much. Then if you do that, we can estimate that your event or med change was sometime between the date of your last follow-up and the date that you signed your current follow-up. When those times happen that you miss a year or two in filling out your follow-up and you had an event, then we're in the position of coding a date for that event that may not be anywhere close to accurate. And that means it might not coincide with the timing of an event, which is really what we're trying to aim for to narrow the field there. Therefore, we will not know that your correct meds or dosages were at the time of a possible event that you had. That's why we ask you to fill in the dates as opposed to leaving them blank. We need to stress that thanks to your willingness to participate, we are able to conduct extensive research on LQTS. This research is able to improve the diagnosis and management of LQTS patients. Every time a paper is published, we report clinical history data, genetic data, cardiac events data, and therapy. No data would be available without your contribution to the registry. So from all of us, thank you.
Thank you very much, Kris. I will share my screen. Can you see my screen?
Yes, yes.
Yeah.
Sounds good. So, as Ilan mentioned, this registry was established by Dr. Moss 40 years ago. And Kris summarized briefly how the registry is working or has been working for a number of years and decades. And the collection of the data from the beginning was serving to further the science and understanding of this disease. So let me start with Dr. Moss's paper from 1971, who at that time described the so-called sympathetic ganglionectomy, or we can call it now sympathetic denervation in patients with long QT syndrome, showing high effectiveness of this modality, which decreases adrenergic response in these patients. In few years later, Dr. Moss, Dr. Schwartz, and a couple of other colleagues, they established formal long QT syndrome registry, which was described at that time as International Long QT Registry. And currently, we have over 1,000 families with over 1,000 probands and now over 7,000 family members. The milestone paper has been published in 1991, showing the first long-term follow-up of about 328 families. This particular paper was important, indicating that probands, obviously, they have high risk of cardiac events, but affected and other undetermined patients who might be also at higher risk should be further studied. At the same time, the same year, there was very good team looking at some ECG characteristics of long QT syndrome patients. As you may even not knowing much about ECG, look at the figure on the left. Normal subject had very homogeneous pattern of ECG, mostly this so-called T wave behind the high QRS. And when you look at example of long QT patients from that study, there was big heterogeneity of those waves in the same subject across various leads on patient chest. Another landmark study, which is always of major interest, was the aspects of pregnancy, how pregnancy could affect these patients over time. And as you see over here, the analysis was done looking at pre-pregnancy period, pregnancy 9 months, and postpartum 9 months. And what we learned that the patient during postpartum period, they were at very high risk in comparison to pre-pregnancy and even pregnancy period. So we learned at that time, over 20 years ago, that pregnancy is relatively safe, but postpartum period is of special interest and requires protection, especially with beta blockers. We subsequently got into the topic of genetics of long QT. At that time, we identified LQT1, LQT2, LQT3 forms of disease. And in this New England Journal paper, we reported that LQT1, LQT2 patients, they had more events than LQT3. But at the same time, we also reported that LQT3 have the so-called higher risk of lethality or likelihood of dying from events. So these data were for the first time indicating how different those types might be. The same year, or earlier a little bit, we look at morphology of repolarization, and you can see that regardless of knowledge of ECG, you can appreciate different patterns of ECG in those different types of long QT syndrome presented here. So these were important findings stemming from exactly this registry. We follow on some association between age, gender, and genotype, indicating higher risk in adults, for women, and in children for males. And what's important, we also learn from Dr. Ilan Goldenberg wonderful paper that long QT is not only the disease of children and adolescents when they have cardiac events. This disease stays with you, and this is a Kaplan-Meier curve which starts at age of 40 and goes for 35 years, so up to age 75, indicating that patients who have QTc above 470 still at that higher age, older age, they have higher risk of cardiac events. There were other important papers in years 2000 through 2005 focus on therapy. Paper on beta blocker therapy, which really became landmark paper for a number of years for people to be guided how to treat patients. We published 2003 first paper on ICD therapy. And in 2005, we had some data from a small subset of patients treated with flecainide with LQT3 form of disease. Dr. Moss subsequently developed a nice collaboration with two additional groups, Wataru Shimizu in Japan and Dr. Arthur Wilde from Amsterdam, whom we have pleasure to have with us today. And this was a collaboration to combine databases, to learn from each other. And those collaboration resulted in really three major papers describing three types of long QT, which are most prevalent. LQT1 in 2007, LQT2 in 2009, and LQT3 by Dr. Wilde in 2016. So this was another outcome which helped us identify patients at risk, patients who might benefit from given therapy. We also focused for a number of years on ICD therapy, and in 2018, we focused on patients who were at risk of cardiac events, but those who are not yet having any so-called sudden cardiac death or aborted cardiac arrest. So patients who are less sick, for whom we wanted to determine what are the best measures. A year ago, one of our colleagues, Dr. Arva Yunis, put together some sex-related differences about which I will say a few words later on in those who had implanted defibrillator. And just 2 weeks ago, we published paper in JACC, Journal of American College of Cardiology, focused on effectiveness of ICD therapy to reduce mortality, and I will also elaborate a little bit on this particular topic.